Assalamualaikum doctors. In this video I am discussing Down syndrome history. How can we manage? So discussion management. First of all, I will assess the patient carefully. I will take his weight and height and plot them on a Down special chart and revise his previous notes and compare the chart with the previous year's chart. I will examine the patient carefully. General examination including the thyroid gland, cardiac examination, abdomen examination, MSK and neurological examinations. I will involve my senior or my consultant if needed and include multidisciplinary team. I will run some tests and investigation to revise his previous investigations in the last visit. Okay. So we are doing TSH, T3, T4. Okay. So again, what I do at the beginning, I will assess the patient carefully. I will take his weight and height and plot them on a Down special chart and revise his previous notes and compare the chart with the previous year chart. I will examine the patient carefully. General examination including the thyroid gland, cardiac examination, abdominal examination, MSK and neurological examinations. I will involve my senior and my consultant if needed and include multidisciplinary team. I will run some investigation, revise his previous investigation in the last year. I'll do the TSH, T4 and T3 level, thyroid antibodies and imaging, ultrasound of the neck with thyroid, radioisotope study if nodules are there. So high TSH, that is high TSH, low T4, primary hypothyroidism, normal T4, that is subclinical hypothyroidism. Normal TSH or low T4, that is secondary hypothyroidism, pituitary or hypothalamus, and severe non-thyroid illness. Okay. TSH, thyroid stimulating hormone, which is the gold standard for diagnosis and follow-up of hypothyroidism. T3 or free T3 triiodothyronine. So TSH is the most important, we will know that. Now, other investigations of Down syndrome are antenatal, first trimester, mother's protein in plasma, beta HCG, non-invasive parental testing, NIPT. So beta HCG, NIPT, antenatal first trimester. Baby ultrasound looking for increase the nuchal translucency. So baby ultrasound looking for the increase the nuchal translucency. Okay. Second trimester triple test and third trimester 14 to 20 weeks we are doing quadruple test. 10 weeks fetal DNA in maternal blood, 11 to 14 weeks CVS chorionic villus sampling, 15 to 18 weeks amniocentesis. These are antenatal tests. Postnatal tests are diagnosis karyotyping, that is trisomy 21. Remember karyotyping, trisomy 21, PCR for rapid result. Blood we are doing full blood count, blood film, thyroid function test, NBS. Imaging, echo, abdominal ultrasound, chest x-ray, overnight oxygen saturations. Others are ECG, vision and hearing assessment, growth monitoring. How can I, these are investigation, I am again telling antenatal and postnatal. Antenatal are mother beta HCG, NIPT, ultrasound of the neck of the fetus because to see the nuchal translucency, that is increase. Second trimester triple test and third trimester quadruple test. 10 weeks fetal DNA in maternal blood, 11 to 14 weeks CVS chorionic villus sampling, 15 to 18 weeks amniocentesis. Postnatal we are doing diagnostic test is genetic test karyotype 21, trisomy 21, PCR for rapid result, blood full blood count, blood film, thyroid function test, NBS. Imaging are echo, abdominal ultrasound because they have lots of GIT abnormality presents like duodenal atresia, malrotation, volvulus. These are chest X-ray, overnight oxygen saturation because short neck. Others are ECG because heart problem, vision and hearing assessment, and growth monitoring. How can we follow up and the multidisciplinary team? Follow up 9 months we are doing audiology, visual assessment to exclude squint, developmental progress. 12 months thyroid function test, thyroid antibodies. 18-month development and growth, check dental health, search for complications like celiac, obstructive sleep apnea, atlantoaxial subluxation, type 1 diabetes mellitus, autism and leukemia. Every 6 months teeth because periodontal disease, malocclusions. Every year full blood count and blood film. 2 to 3 years vision and hearing, thyroid function test, sleep study for obstructive sleep apnea. At every visit, review the parental concern, developmental progress, plot measures on growth chart, and search for hearing and vision problem. So the follow-up 9 months we are doing audiology and visual assessment. Okay, and development progress. 12 month thyroid function test, thyroid antibody. So first year thyroid function test and thyroid antibody. Then 18-month developmental and growth chart, check the dental health, search for complications like celiac, obstructive sleep apnea, atlantoaxial subluxation, type 1 diabetes, and autism leukemia. So 18 months very big. Then every 6 months teeth because of periodontal disease and malocclusions. Every year full blood count and blood film. 2 to 3 years vision and hearing assessment, thyroid function test, sleep study for obstructive sleep apnea. In every visit, what we check, review the parental concern. First of all, review the parental concern, developmental progress, plot the measures on the down growth charts, and search for hearing and vision problems. Multidisciplinary team I am involving for Down syndrome are endocrine, cardiac, chest, dietitian, early supportive services, ESS, SALT, occupational, ophthalmology, ENT, physiotherapist, orthopedics, social service, educational healthcare plan, EHCP, genetic counseling, developmental assessment, thyroxine for lifelong after consultation of the endocrinologist. So our history was Down syndrome with hypothyroidism. That's why thyroxine for the life after consultation of the endocrinologist. Multidisciplinary team for the Down syndrome. I'm again repeating. First of all, endocrinologist, cardiac, chest, dietitian, early support service, SALT, occupational, ophthalmology, ENT, physiotherapist, orthopedics, social service, EHCP, genetic counseling, developmental assessment. About the comorbidities in case of Down syndrome. What is the comorbidities? First of all, endocrine problem in Down syndrome are such at birth, then 6 months, then annually. Hypothyroidism, hyperthyroidism, diabetes mellitus, short stature, and obesity. So these are the endocrine problem. Hematological problem in Down syndrome are transient myeloproliferative disease, acute lymphoblastic leukemia less than 1 year, acute myeloblastic leukemia more than 1 year. Cardiac problems are screened at birth, then at 6 weeks, AVSD, VSD, ASD, pulmonary hypertensions. Respiratory problem in Down syndrome are screened every year. Obstetric sleep apnea, recurrent chest infection, mixed hearing loss, but most common is CHL, then because of recurrent ear infections. Then neuropsychiatric problems are screened each visit, hypotonia, global developmental delay, and autism. Ophthalmological problems are screened at birth, then at 6 months, then annually. Myopia, cataract, glaucoma, Brushfield spot, nystagmus, and strabismus. Gastrointestinal problem in Down syndrome are duodenal atresia, tracheoesophageal fistula, heart-sprung disease, annular pancreas, neonatal cholestasis, celiac disease. Screen in 18 months. So we understand the comorbidities are endocrine problem, hematology problem, cardiac problem, respiratory problem, neuropsychiatric problem, ophthalmology problem, and GIT problem. Then we go the genetic inheritance of Down syndrome. Non-disjunction is mainly 95%. Then translocation and mosaic are translocation 4%, mosaic 1%. Again the cause are non-disjunction 95%, translocation and mosaic. What are the causes of obesity in Down syndrome? Hypothyroidism, hypotonia, unhealthy diet, decreased level of activity, and increased leptin hormone. So obesity are hypothyroidism, hypotonia, decreased activity, then increased eating, unhealthy diet, then increased leptin hormone. So this is all about Down syndrome discussion. Thank you.